Bismillah ar-Rahman ar-Rahim. It's my pleasure to be with you today to speak on the art and science of peripheral and supplementary parenteral nutrition. What is safe admixture in general and in particular to parenteral nutrition solution? A TPN solution is usually isoosmolar. It has a similar osmolarity to the blood. This is in case of a peripheral parenteral nutrition and in case of any IV solution in general. Any solution more than 300 milliosmolar per liter is considered hyperosmolar, and less than 300 is considered hypoosmolar. A safe admixture also has as close as possible to physiological pH. It is sterile or free of life. It is pyrogen free as well, or toxin free. It is particulate free. It is air free. It is stable formula. It is compatible formula and accurately calculated. In the past, we used to say TPN, which is total parenteral nutrition. However, this term is obsolete because TPN can never be total. So that's why they change the acronym to parenteral nutrition. And nowadays, by trend, we call it CPN, or central parenteral nutrition, or PPN, which is peripheral parenteral nutrition. The scope of my presentation today is to focus on the peripheral parenteral nutrition. In general, the methods of feeding are the safest, the more physiological, is oral route, orogastric. If not possible, we make it nasally, nasogastric or nasovaginal, or percutaneously, gastrostomy, jejunostomy, or parenterally, peripheral parenteral nutrition or central parenteral nutrition. This slide reflects my philosophy on parenteral nutrition anabolism ratio. You know, TPN or parenteral nutrition is all about anabolism. It's about civil engineering. It's very similar to civil engineering, where we need the stones, we need the calories, which is the labor, we need the fat, which is the finishing, the cell wall, etc. This magic ratio tells us that for every stone or for every nitrogen or for every protein building or of 1 gram, we need 4 gram of labor or 4 gram of dextrose and 0.8 gram of labor from lipid, which is equivalent to synthesize an amazing cell mass. So this is what we call the nitrogen ratio in a different way, where each 1 gram protein should be combined with 4 gram of dextrose and 0.8 gram of fat. Of course, when we build a building, we need to have all the tools. We need to have the finishing, the aluminium, the interior design, you name it. So those tools are the intracellular ions, mainly the intracellular ions, which is phosphate, potassium, magnesium, and as well as the extracellular like sodium in particular. So in order to build this building or to build a proper cell mass, for each 1 gram of protein, we need to combine it with 0.2 millimole of phosphate, 0.8 millimole of potassium, and 0.12 millimole of magnesium. So to take an example of 50 kilogram patients, for every 50 gram, if we need to feed 1.5 gram protein per kilo, which is the usual dose, we need this mean 1.5 multiplied by 50, 75 gram protein, and by this ratio we multiply 4 gram by 50, and we multiply this by 50, which means a proper nitrogen ratio or proper building happens when we combine 75 gram of protein with 300 gram of dextrose, 40 gram of fat, 10 millimole of phosphate, 40 millimole of potassium, 6 millimole of magnesium. Why I am concentrating on this slide? Because the concept of pre-mixed parenteral nutrition or multi-chamber bags is all about this ratio. That's why all the premix formula are considered balanced formula, where you need various choices of protein therapy, and by default, by following this nitrogen ratio for dextrose and fat, we can have a, a balanced formula. So, ordering parenteral nutrition is an art, science, and experience. And if you give, for example, a parenteral nutrition order form to two clinicians, they end up with the same order for one patient. No, they don't end up with the same order. It's impossible to find exact similar order written by two clinicians. And this will tell us also that we don't have to be very picky when selecting the premixed parenteral nutrition or multi-chamber bags because there is always a variation between 20 and 30%. And same thing, same concept. If you give a tray of food or a breakfast, for example, to two different people, they don't exactly eat the same. So, although we are giving same food and same portion, but the amount to be eaten by those different people are not the same. So again, we don't have to be picky. We cannot say that this premix doesn't offer the 1.6 gram protein per kilo. This is not that significant. And, I always consider the deviation by 20 or 30% to be acceptable. At the same time, there is no standard patient, which means also there is no standard formula. So why we select premixes, including peripheral parenteral nutrition premixes? Because we reduce the compounding workload, we comply with the USP 797 for compounding sterile solution, we have a free time to hang and initiate parenteral nutrition at any time. We have, absolutely like zero chance of contamination, unlike the compounded parenteral nutrition. We have less errors. We have also, it's 20 to 30% cheaper than customized parenteral nutrition. It is less complex in ordering. And at the same time, which is the most important, you can never run out a shortage of medications because all the 20 or 30 elements are available in one bag. So if you have a single shortage of nutrients, this can be solved by having the pre-mixes. And they are convenient for home parenteral nutrition or for patients who travel, because you can send this premix bag in non-refrigerated way. It doesn't have to be refrigerated. And when the patients start the therapy, they need one infusion pump and not two infusion pump as happening with the two-in-one. So the premixes, they are recommended by ASHP and ISMP. And keep in mind that 95% of USA hospital purchased premixes when? In 2008, compared to 88% in 2002. Unfortunately, in our region, we are still debating, shall we use it or not? And the rule is that we have always to make decision based on when others stopped, so we don't have to reinvent the wheel. For anatomy of the venous system, any IV solution below the cephalic vein, is considered peripheral. Anyone which is in upper the area, whether it's in superior vena cava, subclavian vein, is considered the central line. We can have, especially for neonates, a femoral line where the catheter is pushed towards the inferior vena cava and the tip is usually in the right atrium, and this is considered the central parenteral. PIC line is not a peripheral line. PIC line is a central line, but it is peripherally inserted through the brachial line. We insert the vein, but we push it towards the superior vena cava. And keep in mind that the PIC line is not a peripheral line, although it's named peripherally inserted central catheter. So peripheral tip, the catheter tip placement elsewhere than the vena cava is considered a peripheral line. Peripheral catheter are inserted, in the mid-clavicular basilic or cephalic, extended to subclavian vein. This is considered central. If it is in the median cubital vein, or lower, it's considered a peripheral line. And you have the short peripheral line down below, and this is really the typical peripheral parenteral nutrition route. Keep in mind that in the superior vena cava, we don't really worry about the concentrations, various high concentration of various macronutrients, because the flow of blood is more than 2 liter per minute. And when we infuse a solution, we consider a high rate when we infuse 200 ml per hour. This is 2000 ml per minute. In the subclavian vein, it's 800 ml per minute, and in the cephalic basilic, it's 40 to 95 ml per minute, and in the peripheral line, it reaches up to 5 milli per minute. It's very important to understand the dwell time, which is the number of days from line insertion until line removal. It differs between the three catheters. In the lower extremities should be less than 1 week. The midline is 1 to 4 weeks, and in the clavicular, it's up to 3 months. Where there is less contact with endothelial cells. Ideally, for site rotation for peripheral parenteral nutrition is 48 to 72 hours. However, if you have a precious line, very poor venous access, we tend not to rotate. We tend to keep infusing peripheral parenteral nutrition until the patient is really complaining, because sometimes it's very hard to find the peripheral line, and we don't want to put the patient in stress of finding the peripheral line. The risk of complication is 10 to 15% each day above day 2 to day 4. The Infusion Nurse Society recommends that only veins in the upper extremities be cannulated for adult peripheral parenteral nutrition. The risk to peripheral lines is really, we have to understand that the age is a very high risk. We have the chance of losing supporting tissue, elongated and tortuous vein. The long-term steroid also is a justification not to use peripheral parenteral nutrition, because those patients have very poor peripheral venous access. Severe malnutrition, also cachexia, also is a factor. Repeated intravenous therapy like trauma or scarring impacting flow are high risk, and debilitating disease like a patient on palliative care or end stage of life. Those patients, it's very hard to find veins, and as they have a small and very fragile veins. The infusion site failure happens a lot with peripheral parenteral nutrition due to phlebitis or thrombosis, and this is what we call thrombophlebitis, which is thrombus formation leading to inflammation of the veins. It might lead to infiltration, which is non-vesicant fluid outside the vein. It's very important to differentiate between infiltration and extravasation. Infiltration, we use it for non-vesicant fluid, but since TPN is vesicant, we call it extravasation. Any solution that runs out of the venous system is called extravasation, and it might cause necrosis of the tissues. So signs of phlebitis is venous redness, venous swelling, tenderness and pain, venous hardening, venous warming. You have to touch the vein, and we often feel it very warm. Red streaks, edema, sluggish infusion rate, extravasation, and tissue injury. TPN is extremely vesicant, as I said. I keep saying TPN because our mind is really adjusted to the TPN, although parenteral nutrition is the right term. Calcium does not contribute to tonicity, but it's vesicant in nature. It's physically vesicant. That's why in peripheral parenteral nutrition, we tend not to add a lot of calcium, and sometimes you have to eliminate the calcium. Potassium adds to isotonicity, and it's very vesicant as well, very irritant to the veins physically. Sodium contribute a lot to the tonicity, as well as amino acid and dextrose. So up to 45% of patients on peripheral parenteral nutrition really suffers from kind of phlebitis. That's why we have to have a strict policy for site of cannulation, cannula size, dwell time, insertion technique, and catheter care. So what's the difference between peripheral and central? The peripheral is a partial support. It's supplementary. It can never offer full nutrition support. It might lead to phlebitis, as I said, but the good thing is that we don't need to send the patient to surgery for insertion. It's much less intensive. there is much lower risk of sepsis rather than central line. And keep in mind that the maximum dextrose for adult is 7.5%, 10% for pediatric, and neonatal 12.5%. This is a golden number. Tend not to increase above 7.5%. You may tell me the neonates have a very small veins. How can they tolerate more concentration than adult? Because the neonatal veins is a brand new vein. It's the elasticity and the quality of vein that matters, and not the size of the vein. The maximum protein is 2.5%, and the maximum osmolarity should not exceed 900 milliosmolar per liter. However, with central, it's a full support. There is no risk of phlebitis, but sometimes it's intensive, requires surgery to insert the central venous catheter. It's really associated with much higher chance of sepsis. There is no max of dextrose. It's a full nutrition support. There is no max for protein, and there is no maximum for osmolarity. When to consider peripheral parenteral nutrition depends on the degree of malnutrition, the duration of parenteral nutrition, the quality of veins, and if the patient cannot, for example, have a central line or PIC line, then we have to consider peripheral parenteral nutrition. So always ask this question: is my patient a good candidate for peripheral parenteral nutrition? Yes, he's a good candidate if nutrients need can be managed by supplementary parenteral nutrition. Yes, if parenteral nutrition is required for less than 2 weeks. Yes, if she or he has a poor peripheral venous access. Yes, if he or she has a high risk for catheter associated line infection. No, if the patient is already on central catheter. No, if she has electrolyte imbalances. And no, when PN is a bridge therapy to central parenteral nutrition or optimal oral intake. And no, if the patient has any kind of or any type of osteopenia. The contraindication to peripheral parenteral nutrition is fluid restriction. We don't offer PPN to patients with fluid restriction, and any patient with venous intolerance, we don't really offer them any peripheral parenteral nutrition. When the patient is eating enough, we have to stop parenteral nutrition. If the patient is eating a little, then supplemental parenteral nutrition is indicated. Osmolarity, as I mentioned, it has to be as much as possible close to 300, but up to 900 is acceptable. And the physiological pH close to 7.4 is the safest. However, it's impossible to have this pH for TPN. The average pH is around 5.4, but we always say that a pH of 5.8 is much safer than 5.4. So as close as the normal pH is acceptable. So how to calculate the osmolarity of parenteral nutrition? Very simple. You just take the dextrose concentration, you multiply it by 50, the gram of amino acid, you multiply it by 100, and the millimole of cations, you multiply by 2. So if you don't want to calculate each millimole separately, just add the 300 and it gives you a very close estimate. So osmolarity, as I said, the maximum for adult is 900 milliosmolar per liter. And the maximum for amino acid is 2.5%. Sometimes we tend to increase to 10%, but I truly don't recommend it. Preventing peripheral parenteral nutrition complication, as I said, keep it at 7.5 for adult and 12.5 maximum to neonate. Maximum protein is 2.5% for adult, 3% for neonate. You need to calculate the final osmolarity less than 1100 for neonate, less than 900 for adult. We add heparin and hydrocortisone sometimes for some patients, and we reside the vein every 24 to 48 hours, and we minimize as much as possible. We add a quarter of normal saline, sometimes not more. Potassium, we tend to keep it at as low as possible, like 40 millimole per liter, 60 millimole maximum, and calcium maximum of 2.3 millimole. Sometimes I tend to not to add calcium. And this is very important. IV lipid is considered an emollient to the vein. It does not lead to any type of phlebitis. Sometimes we give higher dose to treat phlebitis. And those patients, we usually in peripheral parenteral nutrition give up to 2 grams per kilogram per day. So we interview the patient, we consult the IV nurse, we take a proper history, we give all fluid through peripheral parenteral nutrition. Adult in general, we give 120 ml per hour. We monitor respiratory function, the fluid overload, the renal function, the intake and output. The step-by-step guide, we always we need to encourage the oral intake. We ask the clinical dietitian to assess regularly by doing a calorie count, and we educate the patient on risk of venous intolerance, and we ask a nurse not to manipulate the rate at any one time. The TPN rate should never be changed unless if it's approved by the clinician, clinical pharmacist, or a physician. The IV lipid, as I said, it protects vein from phlebitis, improves tolerance, and it is safe at high doses. The dose, we give it 1.5 gram per kilo. Sometimes we give up to 2 gram per kilogram per day. We infuse as long as possible, over 20 hours. We allow 4 hours lipid off before taking a blood sample. And in general, we don't exceed 0.15 gram per kilogram per hour. IV lipid in, TPN, promote the longer patency time, better tolerance, increased pH, and tolerance up to 13 milliosmolar per liter. In general, 63% of patients tolerated, this osmolarity. However, we always say 900 is the maximum. And the osmolarity, as I mentioned one more time, sometimes you have to take some exceptions for patients who need calories. I tend to increase a little bit more than 900 or 1,000, but this requires a very close monitoring. What to monitor with high dose lipid, platelet, triglyceride, signs of sepsis and respiratory distress in neonates. To improve the tolerance of peripheral parenteral nutrition, we add 1 unit of heparin per each ml. And hydrocortisone, we add the sub-physiological dose like 10 milligram per ml. Sorry, this is 10 milligram per 1 liter. It's not per ml. Topical NSAID might be recommended at the cannulation site. And there are some studies of giving nitroglycerin or glyceryl trinitrate to cause vasodilation. So hydrocortisone and parenteral nutrition, this is a nice study in 1995, and the catheters in the study group survived longer and resulted in lower incidence of thrombophlebitis. Heparin in neonatal, it doubled the duration of catheter patency and third of the incidence of thrombophlebitis. It is 5.7 versus 17.2% less chance of phlebitis. This is another study where the addition of heparin is a factor of enhancing venous intolerance, and in this study there is no improvement when heparin is added. So it's not a must to add heparin, but I really recommend it for patients adding 1 unit per ml. Hydrocortisone is only added for patients with severe risk of phlebitis. Keep in mind that those side effects that might happen, and it's reported that 1,000 units of insulin was added by a pharmacy technician instead of 1,000 units of heparin. Why PPN is safer than CPN? Because it has a lower risk of hypoglycemia upon discontinuation. You don't have to taper parenteral nutrition, the peripheral parenteral nutrition, at any one time when you stop it, because the dextrose concentration doesn't exceed 7.5 to 10%. It is less likely to cause metabolic complication. It is when the CPN is intracardiac, the PPN is not. The PPN contains much less toxic ions like potassium, magnesium, and phosphate. And remember that potassium is identified as the drug most commonly implicated in fatal incidents in acute care facilities. So filter must be used. It can prevent microvascular pulmonary emboli. It helps preventing infusion-associated sepsis. We use 0.2 micron as a bacterial retentive filter, but now the recommendation, because 0.2 micron is hard to find, 1.2 micron is now recommended, and fortunately it retains candida. It reduces the chance of phlebitis. So what we do, we put the filter, as close as possible to the patients. It's distal to the infusion pump. So we place it below the Y site, filter as close to the catheter hub, the filter to be changed with each tubing every 24 hours. This is a clinical scenario. I have 5 minutes left. This patient, Adil, started on CPN 2 liters. The physician ordered dextrose 8%, amino acid 3%, sodium 80 millimole. As you can see, high dose of potassium and calcium, relatively high dose, calcium that's recommended for central parenteral nutrition. The central line was ordered through external jugular vein. The RN started CPN at 80 ml per hour. Unfortunately, and this is a real case, the nurse called me saying, Osama, please come to the unit. The patient is having severe neck swelling with severe pain. So what went wrong with this patient? The patient started on CPN, chest X-ray, unfortunately not checked. The tip of the catheter is not located in the right place. So the patient had uh, extravasation from the jugular vein to the neck area, and the patient was taken to OR for debridement of necrosis. So, Adil, as I said, these are, the elements. The physician now said, let's order the same formula but peripherally. And, here we have to really do some calculation. Can this same formula given peripherally, we said 7.5% maximum, but this is 8%. We said amino acid 3% and the maximum is 2.5%. Sodium is relatively high, potassium little bit high, and 6 millimole is really high. So we do some calculation to make sure that if this solution can be infused above, formula peripherally. And, sorry. We need to always calculate the osmolarity, multiply 8% by 50 to give 400, amino acid 3% to give 300 milliosmolar per liter. Sodium we multiply by 2, as I mentioned, potassium by 2, and calcium by 2. This end up with a total of 860 milliosmolar per liter, which means that, relatively, if the patient has good peripheral line, we can infuse this one safely. However, we don't want to discard the formula. We can give it peripherally, but I make sure, because calcium was 8 millimole, we make sure to reduce it to 2 millimole as possible. So can we infuse? Yes, for the answer. So now Adil complained of severe pain at the injection site. He's having phlebitis. Unfortunately, the patient did not tolerate the solution. So the nurse called us and asked if she can reduce the rate from 80 ml to 40 ml per hour to reduce the venous intolerance. So does rate reduction reduce venous intolerance? First of all, if we give 80 to 40, we reduce the calorie intake and the protein intake by half. So this is not recommended. But the best answer is that we do not recommend at all to reduce rate to reduce the chance of phlebitis. So it's not really the rate that is impacting phlebitis, it is the concentration, it is the osmolarity of various nutrients, and it is really the potassium and calcium, which are the main culprit because they are physically irritant in nature that are contributing to phlebitis. So the answer is no, it's not the rate, it is the components. What we recommend here, we hold parenteral nutrition and replace it with D5 water at the same rate of parenteral nutrition. So wrap up, there is no standard patient, which means there is no standard TPN or no standard osmolarity. We have to always assess properly and give the TPN accordingly. To program your software, we have to use numbers, and we use a maximum of 900 for adult and 1100 for neonates and 10% for pediatric, which is 1000 milliosmolar per liter. If your patient is osteopenic, don't go with peripheral parenteral nutrition because we need to give a large dose of calcium. If a patient is severely hypokalemic, we consider a central line, and we consider heparin 0.5 1 unit per ml with peripheral parenteral nutrition, unless if the patient has a very low platelet or any other contraindication. We give less sodium, we give less potassium, we give less calcium with parenteral nutrition peripherally, which means better tolerance of peripheral parenteral nutrition. Outside the ICU, PPN is the choice for short courses with early PO and NG feeding. And thank you very much.